I'm an independent healthcare consultant majority of the time, but I'm actually a strategic clinical advisor to 4 CCGs, 2 commissioning support units and 2 of the national Royal Colleges. I'm also a director of strategic development for a provider organisation. But I'm here today to talk through my life as a commissioner. And I apologise if I don't talk about the rhetoric, but it's about talking about reality. It's about what we do on a day-to-day basis. So my work with the CCG, I've worked with one of them for 6 years and some of the others between 2 and 3 years, is to help drive their commissioning plans. It's to help them achieve their cost improvement programmes, their SIP targets and programmes. So it's really much about sort of helping them understand where they need to be. And I can tell you over the last couple of years that work has got more and more difficult and more problematic in the sense that we've had less money in the system, but actually the targets have got more strenuous and more onerous, and actually our performance is being squeezed year on year. And it echoes what Kerry was saying about this year, hopefully, we'll be doing less planning and more doing, and it's more about implementation, but I'll come on to that in a moment. So I thought I want to put it into context about what is this mysterious beast called commissioning. And very simply, through the Health and Social Care Act, it passed the responsibility of just under 70% of the NHS budget to CCGs. And commissioning is about being custodian of the public purse, really, to look at the health needs of a local population and to purchase or commission or procure services which meet those needs. It's as simple as that. And I think one of the difficulties we've faced over the last couple of years that because we've been labelled a commissioning group or NHS England, doesn't necessarily mean we've necessarily been fit for purpose. So I think there's a real lack of understanding out there about what commissioning really is. And I also want to state the obvious, really. There is not one person called a commissioner. There is not an organisation called the commissioner. And the times that I meet people and I say, I can't see the commissioner. There's not one person with a big furry hat on. It's a number of people and it's a complex process. And I think it's important for you to understand, and I apologise if I'm teaching you what you already know, but I think it's really important to understand that it's a very complex process, and actually it's undertaken by groups of people with different skills and different levels of expertise, and you need to be making sure you're talking to the right people, but more importantly, you're talking to the right people about the right things. The language is going to resonate with them when you're in a meeting. So this is the commissioning process. It's a commissioning cycle. It doesn't have a natural start and an end point, but it is cyclical. So you've got the transformational bit, which is stuff I love. It's about service development, service strategy, it's about the visioning. The majority of that is not done by accountants or performance managers. That's the transactional side. But actually, don't underestimate the importance of the transactional bit. That's where, once we've done the visioning, once we've identified what the gaps are, it's then over to people like me, because in a previous life I was an accountant, where we start looking at the numbers. And that's what drives the performance stuff. So in my view, if you can help me do some of the work that I've got to do to drive some of that demand down and make sure that we're managing our system and our contracts appropriately, that's a good thing to do. Are people all aware of the commissioning process and how who does what at which point? No. So you're going to have people in the transactional side. So you've got it starts with the JSNA. You've got the public health teams and the clinicians are actually saying this is the needs of our local population. What services have we got? What gaps have we got? And they basically do a big detailed gap analysis. And it's from that we develop our commissioning intentions. If your services or the services or products that you provide aren't part of that JSNA or commissioning intentions, it's going to be very difficult for you to get inside a CCG, because actually it's not going to lead my priorities. It's then about looking at the service redesign and service improvement opportunities. So again, it's understanding where you fit in your local healthcare economies. Are you in the priority list, and how can you influence that? And then it goes out to the tendering and procurement that Kerry was talking about before, and it goes on an annual basis. You need to understand the time frames within your local healthcare economy, so actually you not just align to the right people, but you align to the right people at the right time. Because again, there's nothing more sort of annoying, really, that you do all this work and you turn up 6 weeks after they've agreed their budgets and you've got to wait for next year. And sometimes it's the very simple things that people often don't understand, but don't be afraid to ask. When is your planning round? When you're looking at capacity planning, who's leading on it? So what do my current weeks look like? And this also goes into night times at the moment. There's a current round of performance meetings. The last couple of weeks I've spent probably 80% of my time during the day going into meetings looking at the performance for last year and why we haven't achieved our targets and trying to model their performance for next year. And last week we signed our ETO off with our local trust, and actually we had the deadline was the 4th of March, it was last Wednesday, and actually we had days to agree. It's a very complex thing, and our CCG locally we've already started off with a £2.5 billion shortfall from last year. So it's real. So even before we start on the 1st of April, we know from the modelling we're already we've got problems. I think one of the things for us as CCGs, and I think it's the same as everybody around the country, we go from one sort of planning round to another. And I think my challenge is that we're still not doing it. We're doing a lot of thinking, planning and strategic visioning, but in my view we're still not doing a lot of the doing, because actually we've still got to go through the hoops and hurdles for the performance management. So my week at the moment, I think we've got the Pareto principle the wrong way around, 80% thinking but 20% doing.
And what sort of time period are you planning for at the moment? Is it for the financial year from April? Or
Yes.
So it's quite immediate, short term?
Yeah, so even though we've got the view for next year, we've got to get the coming year right, and we've got to take into account what we haven't achieved for this year, because we haven't achieved the performance targets and the financial balance that we needed to. So we've got to unpick why we didn't do that this year and move that into next year and then carry on. But also we've had to develop longer term plans for 16, 17 onwards. So it's a constant sort of rejigging of the books effectively. And it's a very robust process. We work with our trust on we've been meeting on a twice weekly basis, because actually we need to make sure that what we're saying that they're agreeing to. So it's in our case it's actually broken down some of those barriers, and the ETO last week could have completely rubbished that bit, it didn't, but we're very quite fortunate. So what's important in my world, in the current year, is achieving national KPIs. They're the imperatives. There are some things that we would like to do, there are some things that we could do, and arguably there are some things that we should do, but the things that keep us awake and actually keep us in jobs are the imperatives that must do. There's a real drive to achieve A&E waiting times. The trust that I work with through the CCGs are struggling on a day-to-day basis. It's very, very rare that any of the trusts that we've worked with over the last 18 months have achieved their A&E targets on a consistent basis over 4 weeks. There's a real drive to make sure we achieve all the outpatient targets, so those things are there all the time. The biggest thing as well is you've got to achieve all of that whilst you're achieving financial balance, so it's not an either or, it's all of them without compromising patient care. Next year, one of the things that we've obviously got to do is make sure that we achieve all those targets, but look into the 5-year plan. It's what Kerry was saying before, it's about embedding some of those changes. So, the things that keep me awake at night, apart from having a late night meeting last night with Monitor, which was really interesting, if you want insomnia, is how can we reduce emergency admissions? That is a burning issue for every single healthcare economy, whether it's a CCG or whether it's a provider. We are experiencing unprecedented amount of growth in emergency admissions, and we don't really understand why. The only thing that I can say is that I would say 90% of those patients are really, really poorly, and actually they need to be there. But it's about, but they stay quite a long time, but there's still a lot of patients who don't need to be there, and they're the ones that are actually really causing the logjam. How can we shift work from secondary care? So how can we move it out? There's a real need and an imperative to redesign and improve care pathways, and I've got a real thing about that we still send patients into a hospital because there's a building called a hospital. And I think there's still a huge opportunity to completely redesign the pathways of care based on what patient needs are rather than a physical building. So that's a real challenge. And I think some CCGs still need the help to vision some of that. because it's very easy for us to go into the same old conversations with providers. We'll send you less, and it should actually be sending a different balance of patients. I think one of the things it's about, we need to make sure that we're working within our activity envelope and our financial envelope and making decisions about how we do things differently, and in some cases what we stop. And that is a real issue. I work in one of the CCGs down in the southwest, where our neighbouring CCG, not the CCG I work with, has initially put out a stock list of 40 services, and it wasn't allowed in the end, but actually it's those tough decisions. So again, it's about how we do things differently. All of this is about impacting patient outcomes. So we've got to do all of that whilst making sure that services are safe and patients get the services they need. How do I currently engage with industry? It's very patchy. Invariably it's down to long-standing relationships, and it's about trust. I think there is still awareness, and I think it goes back to my little chart about the commissioning process. I think some people still don't understand the role of non-clinicians within CCGs. My phone very rarely rings, which the last couple of months have been amazing, but actually I would quite like someone to phone me up and say, I've looked at your priorities, I've looked at what your issues are, and I think I can help you. And I don't think there's enough of that, because people like myself, we hold a big budget, we've got a responsible job. We may not be clinical, but actually we're influencing what's happening locally. So it's sort of understanding who's out there.
You are very difficult to pin down, though.
I
know, with the layers of obfuscation
within
within all the websites.
Yeah,
I mean,
I
think most of you work for the SAS or something like that.
You've
got other jobs in Iraq.
MI5. SAS. I don't like.
I'd love to call it. Just trying to get all of this.
Yeah, well, we like to be very low key. I think one of the things for me is about when companies come to me and they've got something which will help me do my job. It sounds very selfish. Don't come to me with something that's going to give me more work. It's coming to me with something which is actually evidence-based and actually going to help me do something. I think it's about when people come to me about sort of telling me that they know what my problems are, rather than, oh, what is your problem? There's nothing more annoying than giving someone 15 minutes and actually then they're just regurgitating what you already know. I think it's also about leaving a legacy. Again, we've had too many instances where industry and also parts of the NHS have come in and we've done something, it's like a prop up. And actually when that prop has been taken away, the system falls over. For me, it's about sustainable change. It's about changing the way people work and having sort of longevity. So it's not a short piece of work, someone comes in, drops a nurse in. Those days have gone. It's about helping us work in a different way. And also, I've used this before, in some cases it's about giving me a solution to a problem I don't even know I've got. I'm responsible for hundreds of lines of a budget. I can't possibly know every single line in those budgets. And if there's something in there which you believe you can help me with, even give me some information and data, you may target me into an area that I've never looked at before. We're all too busy looking at the big, sexy stuff at the top. But actually, there's an opportunity, I think, to sort of be more granular and give me the information that I need to try and make some of those decisions. What I don't like is about being given a solution which fits the needs of the industry, and I know that's very, very difficult because you've got a business, but it's about sort of being mutually respectful. It's about what's something that's good for you, but also what's good for me, but more importantly, what's good for patients. And I think also what I said before is about longevity. It's something that shouldn't be dependent on one or two people. And also about, so often we've seen projects or pieces of work where they've got a very narrow scope, and we've often not looked at the long-term consequences, and we're not very good at actually saying what's the impact further down the line. That's why some cases I think joint working with pharma hasn't worked, because actually we need to look further down. So it's about looking at the whole process of care, the whole pathway. There's nothing's new, but I think it's being more accepting of it. So why would I sort of engage with people in this room? It's about helping me change that 80-20 split. It's about helping me do the doing and the implementation, so that this time next year I'm not feeling as fraught as I am thinking we haven't achieved this year's targets. my God, we've got to start thinking about it in 3 weeks' time. And it really is helping me do some of the work that I've got to do. And at the end of the day, it's trying to make my life easier. And I think for me, it's about all doing it together. And it's about equal partnership. And I think it's making sure that whoever you partner with is aware of their requirements as much as yours. It's not too. I think in some cases it's not two-way. It's too easy for the NHS to walk away from it. So I think you've got to get the ground rules right to begin with, and actually say we're in this together. But actually, you're only going to get that if it's something that I really want to do. It's about doing the things that I've got to do. It's helping me achieve some of the imperatives. Maybe not directly by the project that you want to propose, but it's given me time and space to actually do some of that stuff. And I think it's about developing a strategic partnership about trust and building relationships. Thank you very much.